Thank you. Good morning, and thank you for inviting me. Today, I will tell you the story of how a condition is added to the newborn screening panel in the United States. And well, I have nothing to disclose. So I'm going to focus on GAMT deficiency, guanidinoacetate methyltransferase deficiency, which is one of the cerebral creatine deficiency syndrome. Cerebral creatine deficiency syndromes, just to, summarize, these are caused by defects in creatine synthesis or transport. They are characterized by a similar clinical presentation, intellectual disability, autistic-like behavior, seizures, speech and cognitive delays. And they can be identified, diagnosed using biochemical test, molecular test, and MR spectroscopy, as we have seen yesterday. The therapy, at least for the defect in creatine synthesis, the therapy, if it's initiated early in life, is quite effective. The first defect, agate deficiency, is the therapy for the first defect is creatine supplementation. For GAMT deficiency, is the goal of the therapy is both to supply creatine and to reduce guanidinoacetate. So in addition to creatine, the therapy consists in ornithine and benzoate supplementation to reduce, again, with the goal of reducing the concentration of guanidinoacetate. For creatine transporter deficiency, there is not yet an effective therapy, but I'm pretty sure that we're going to get there. And some patients may respond to creatine, arginine, glycine supplements, or betaine. So let's look at the pathway very briefly. Creatine is synthesized starting from arginine and glycine, and the first enzyme is arginine glycine amidinotransferase, or AGAT, that converts arginine and glycine into guanidinoacetate. The second reaction is, is catalyzed by the enzyme guanidinoacetate methyltransferase, and with the transfer of a methyl group, you have the synthesis of creatine that then is taken up by tissues through the transporter. If we have a defect in GAMT, in guanidinoacetate methyltransferase, you have an accumulation of guanidinoacetate, and you have reduced creatine. And this is important to keep in mind, that there is this elevation of guanidinoacetate, and this is important for newborn screening, especially because with newborn screening we are very good at identifying markers, analytes, which are elevated. Those that are low are more difficult to identify. So conditions that are characterized by low concentration of analyte are more difficult to identify effectively or efficiently by newborn screening. I have mentioned that the cerebral creatine deficiency syndrome can be diagnosed through biochemical test, and this table summarizes what we find when we are measuring guanidinoacetate and creatine in plasma and urine. In agate deficiency, we have low concentration of creatine, low concentration of guanidinoacetate. In my experience, guanidinoacetate is 0 in this patient. In GAMT deficiency, we have low creatine and high guanidinoacetate in plasma. In creatine transporter deficiency, creatine and guanidinoacetate are normal in plasma, but we are seeing an elevated ratio of creatine to creatinine in urine that allows the diagnosis of this patient. Then, of course, the diagnosis is confirmed by DNA testing. So we have talked about newborn screening and how this is, for GAMT deficiency especially, having a marker that's elevated is important and allows newborn screening. So the definition of newborn screening is that this is a public health activity aimed at the early identification of conditions for which timely intervention can lead to the elimination or reduction of mortality, morbidity, and disability associated with this condition. So what this means is you need to have a marker that can be identified in the newborn period. So you need to have a screening test. You need to have a confirmatory test that can tell you, yes, what you have found is true. This baby has this condition. You need to have a therapy, and the therapy has to be effective. So when we started working on newborn screening for GAMT deficiency, we knew that we had a marker that was guanidinoacetate. We knew that it was identifiable early, before the patient became symptomatic. We had confirmatory testing, and we knew that the therapy was effective. So the goal, we started a pilot project with the goal of integrating screening for GAMT deficiency in the regular screening. And this would have allowed to do this without additional sample, which is important because these are tiny babies and we don't want to bleed them unnecessarily. And also because this would have allowed newborn screening with minimal additional cost. So basically only the cost of the reagent, the additional reagent. The extraction of this analyte occurs the same way and simultaneously with amino acid and isocarnitine, so it doesn't require an additional process, doesn't require additional personnel or additional instrument. We used as a primary marker guanidinoacetate, and also we used a secondary marker, which was the ratio guanidinoacetate to creatine. So in this slide, I've summarized the results of the pilot project. I apologize, the x-axis doesn't have labels, but the x-axis represents age of collection of the blood spot. In Utah, we mandate 2 screens. The first screen is collected before 48 hours of age. The second screen at the time of the pilot project was collected between 7 and 28 days of age. So the x-axis represents the age in days from 0 to 31 days. And the y-axis, the concentration of guanidinoacetate in blood spots. The open circle represents the control population, and the black squares represent patients confirmed to have GAMT deficiency. So the first 3 patients, the first 3 squares were collected on the, before 7 days of age as part of the first screen, And the last 4 squares were collected after 7 days of age. So 2 things that you can appreciate from this graph is that the concentration of guanidinoacetate in the control population does not change with age. It's pretty constant. And the second thing, very important, is that the difference in concentration of guanidinoacetate between patients with GAMT deficiency and control population is extremely high. So this makes it very easy, in a way, easy to do newborn screening. I have talked about the secondary marker, and we added the secondary marker, guanidinoacetate, the ratio guanidinoacetate creatine, to increase the specificity of the screening. Here we have on the x-axis the concentration of guanidinoacetate and the ratio on the y-axis. The vertical dashed line represents the cutoff for guanidinoacetate. So basically the concentration which we said, okay, above this concentration, everything is considered a presumptive positive. And the horizontal dashed line is the cutoff for the ratio guanidinoacetate creatine. So you can see that if we use only the guanidinoacetate concentration, we have a lot of black circles that represent the control population on the right of this line. But when we add the ratio, now the presumptive positive are going to be those samples that fall into the upper right quadrant. So the red circle are patients with GAMT deficiency. The black circle is the control population. So we are reducing the false positive number. To reduce it even more, we designed a second-tier test. A second-tier test is a test which is run on the same sample that's used for the primary screen, so does not require to contact the family or to collect an additional test. Usually, you can use a different methodology or target different analytes. In our case, we added a chromatographic separation before the detection by tandem mass spectrometry. Once we introduced the second-tier test, the false positive number was basically reduced to almost 0. So at this point, I want to go back and tell you what is the path to include a condition in the newborn screening panel in the United States. So we have what we call RUSP, Recommended Uniform Screening Panel, which is a list of conditions for which every child in the United States should be screened. And again, is recommended. As you know, the United States are united except for newborn screening. Every state does whatever they want. The government can recommend at the federal level. They can issue a recommendation, but every state then decides if, when, and how to implement this recommendation. So in order to include, to add a condition to this RUSP, you need to nominate this condition to a committee, the Advisory Committee on Heritable Disorders in Newborns and Children. This includes a researcher, clinician, professional organization, advocacy group, and consumer. Within this committee, there is a work group that looks at this nomination and decides if there is enough evidence, well, actually summarizes for the committee what they have learned, and then the committee decides if there is enough evidence to proceed to a full review. And the full review is done by an external condition review work group. And the full review takes about 6 to 7 months to complete, and ends with a recommendation for the advisory committee, which then votes on adding or not the nominated condition to the RASP. And then finally, the Secretary of Health and Human Services makes the final decision with a signature on a letter that says the condition can be added to the RASP. So we thought that we had everything in place to nominate the condition. But we did have all the elements that were necessary, but not in the right order according to the committee, because we had not identified yet a baby with prospectively with a newborn with a GAMT deficiency, so they were not sure whether the system would have worked. Yeah, frustrating. So we implemented in Utah newborn screening for GAMT deficiency in 2015, June 1st, 2015. We used a derivatized method, and we used a second-year test. In 2019, the newborn screening was performed in our lab, which is a part of the University of Utah. In 2019, the Utah Department of Health moved the newborn screening back in-house, and they switched the method to an underivatized method. In the fall of 2018, New York State started screening statewide for GAMT deficiency, and they used the same method that we used originally, derivatized method, second-year test. They were doing a lot of second-year testing, and this was because there was an interference in the measurement of guanidino acetate. So they optimized the acquisition method, and they were able to eliminate the second-year test, which is very important because not all the in the United States, the screening laboratories do not have the capacity to do second-year test. Finally, at the end of 2020, Utah identified the first baby with GAMT deficiency. And a couple of months later, New York State identified another baby with GAMT deficiency. In this table, there are summarized the value for guanidino acetate, for creatine, the number of false positive, and number of second-year tests. One thing that I just want to point out that no matter what type of method you use, whether you use a derivatized or underivatized method, if you look at the value for guanidino acetate, and again, in the second column, those are the average of the population. The values are the same. So, in other words, this screening works, no matter which method you use. So we identified these two individuals in two babies. They are doing great right now. They are they've been treated since birth, and they are really doing very, very well. In Utah, our false positive rate combined was very, very low, 0.0007%. So I personally think that this screening is a no-brainer. But finally, this was the missing piece. We nominated the condition again, and after 7 years, like Heidi pointed out yesterday, the advisory committee voted unanimously in favor of adding GAMT deficiency to the RASP. So where are we now? You have seen this slide yesterday. There are 3 states that are currently screening for GAMT deficiency. There are other states in which the screening has been approved, but they have not started yet. They still have there are still some technical challenges, and there are states in which the legislature requires that they add this condition. Once it's added to the RASP, they have to add it. And others are not yet considering it. But we are working very closely with these states to offer our assistance. The Association for Creatine Deficiency has been very instrumental in doing this, as it's been very instrumental in getting this condition nominated and approved. So, in a summary, newborn screening is feasible and it's effective for GAMT deficiency. The false positive rate is extremely low. The path to include a new condition to the RASP in the United States is long and challenging. And I think that a partnership between clinicians, scientists, public health, and parents, especially parents, is really the key to success. Thank you.